Hello and welcome to the Chest X-ray Interpretation Bootcamp module. And what we're going to accomplish in this module is being able to quickly identify any type of chest X-ray abnormalities, as well as being able to understand what we need to do with those abnormalities. So let's start with interpretation. There's several different methods you can use. We perform the ABCDE. There's also the inward-outward. So we're going to go through the ABCDE first, and then I'll show you another way you could do that as well. So speaking from the ABCDE, understanding what that mnemonic means is very important, obviously. Airway, breathing, circulation, diaphragm, and then any extras. So the airway is just that, looking down right through the midline, looking at the trachea, the mediastinal width, trying to evaluate if you have any mediastinal widening. For our aortic injuries, the aortic knob itself, which is going to be right in this area, if it's highly pronounced to the left of the patient, then that might be concerning that there is something more nefarious going on. A deviated trachea, anecdotally, I've seen deviated tracheas, but you also have to remember that understanding the rotation is very important of the patient. If the patient isn't directly in the middle of the bed and they're right on both clavicular area, then you may have some type of rotation, thereby causing a inappropriate deviation. But once you do see a deviated trachea with clinical context, it's very important so that you do not miss that. The next one is going to be breathing, looking at the lung fields, looking around the exterior of the lungs, determining if there is any type of pneumothorax. It's difficult to appreciate a pneumothorax, mainly in the apices, but when you do see a pneumothorax, it will be a darkened space, and what you want to do is you want to evaluate into the pleural external fields, trying to evaluate, see if you have lung markings all the way out. If you have the lung markings all the way out, then that's probably not going to be a pneumothorax. But remember, the X-ray is a snapshot in time. It's obviously not a CT. You can't do slices. So if you have an index of suspicion that there's a pneumothorax going on, and they do still have breath sounds, but you're kind of questioning, then you need to reflex to a CT scan of the chest. You're also going to evaluate for symmetry, looking at the pleural linings, like I mentioned before, and you want to evaluate for your gutters here. If you have a really deep gutter or your costophrenic angle, then that might indicate that you do have a pneumothorax. Or if you see leveling out, then that might mean that you have a effusion or empyema or something like that. So going to the circulation, looking at the heart. Remember, there is a difference between an AP and a PA film when it comes to the heart size, just based on where the radiation is going through the X-ray. So if you're looking at the AP and PA, if you want to evaluate the heart size, you really need to get a PA film. But that being said, if this is just a screening X-ray and the heart is literally 2/3 the size of the chest wall, then most likely you have cardiomegalia. In addition to that, you want to evaluate the heart shape, the heart borders. Sometimes, say for example, you have someone who's been chronically vomiting. Now they have, Hampton's crunch, or things that are really, hot button words that we learn about when we take these exams. You can see pneumomediastinum if you see a black airline along the context of the heart. Now, seeing that in the clinic is not as prevalent. These are more of emergency things, but you never know. If you're watching urgent care or whatnot, if someone comes in, says I have chest pain, you get a chest x-ray, and the reason why you do that is you want to look for other causes of chest pain or the distractors. So looking at the diaphragm here, it's very important that we evaluate the diaphragm levels. Obviously the right's going to be a little higher than the left just because that's where the liver sits. But when you do get this, you need to evaluate the diaphragm shape and contour, because say for example your patient's having chest and abdominal pain, they were just involved in a motor vehicle incident, you're listening to the lung sounds and you're like, man, I hear some, lung or bowel sounds in the chest. That could be a diaphragmatic rupture, and it does happen on the left more than the right, and specifically the posterior lateral aspect of the left diaphragm. And so you can have your diaphragm all the way up here pushing the lung up, which contextually the patient may also have some shortness of breath with that as well. As mentioned before, your costophrenic angles, don't forget to miss that, and do not forget to miss any type of subdiaphragmatic free air. So this would be pneumoperitoneum. This is a surgical emergency, as those are the easy questions on the exam. So it's more likely to find a air bubble than subdiaphragmatic free air, and that's because the gastric bubble will be on the left-hand side. Now on the right-hand side, if you see a black sliver of hypoechoic space on here, then that's most likely going to be a surgical emergency. Other things that you're going to be questioned on is the nasogastric tube. You put one in, you have to get a chest x-ray. If the nasogastric tube tip crosses the diaphragm and you see a little bit more over here, it is in the stomach. This is not the lungs, meaning that if it goes over here and it terminates here, you put it in the wrong hole. Pacemakers, you can see single or dual chamber, and those the pacemaker may be over here on the left chest wall or the right chest wall, and it depends on what type of pacemaker they have, and you can identify if they have a single or dual chamber just based on the amount of cords that they have visible. ECG electrodes can be distractors. Make sure that you're understanding that if you see a big old white dot, that might not be a cancer, it may be just an electrode. PICC lines, and central lines, if you go from the IJ or the subclavian approach, you need to make sure that it terminates right around here, and that would be the superior vena cava. If you're doing a femoral, you don't need to do a chest x-ray. It's just understood that it's going to go and you want to hub it. But we'll talk more about that in procedures. Foreign bodies, an endotracheal tube, it needs to be at least 3 centimeters superior to the carina. And here you can see this is where the carina is at. You can see that's where the left main stem bronchi and right main stem bronchi are going. And this right here is the carina, so an endotracheal tube would need to be right around there. And the reason for that is flexion extension of the neck can easily displace that. So making sure that your rotation is appropriate, that your exposure is appropriate. You want to be able to see all of the lumbar, thoracic, and cervical vertebra through the x-ray here. And if you have over or under exposure, you can manipulate a little bit with the PAC system that we have in the chart, and that might be able to help you a little bit more. But remember, if your initial shot is not very good, then your interpretation may also not be very good. So moving on to your algorithm, the alternative way, which is starting from the center moving out, is same stuff. You look at the trachea, bronchi, heart, mediastinum, and so on until you get to the chest wall. So if you find an abnormality, then you're going to go to the appropriate step and then evaluate the remaining steps. So let's say, for example, you're going to the trachea and then the heart, mediastinum, hyla, and the lungs, there's something abnormal there. Then you bring that one and you stop and you say, okay, what do I need to do? And you focus in on that. So if you don't find an abnormality, then you would just continue to go on and continue in that center and moving out. And remember, this is an alternative approach. So the trachea and bronchi, obviously the normal, you see in the middle, you see with your mind's eye, and it takes a special amount of time, if you're not familiar with looking at chest x-rays, being able to differentiate the subtle hues of gray, which sounds silly, but if you do that and you are able to see the carina in your mind's eye, it takes a moment. You just got to look at it, and you have to not focus, you have to defocus, and then you can see the subtle objects. If the trachea is deviated, then that might mean that there's some type of mass effect going on. Obviously, if there's a trauma, that may be something else more nefarious is going on. Or if the carina itself is greater than 90 degrees, then that might mean you have hyperinflation or lung damage as well. So if there's narrowing of the trachea, like laryngomalacia, then you might have some other issues going on, especially with our youth that may experience this. In addition, people who are post-op from tracheal or bronchial injuries may also have that. Again, you can also have mass effect from this. Is there a visible mass itself? If that's the case, well, then we all know where that goes. It's going to go to oncology and surgeon. So the heart itself, making sure that you evaluate the cardiopericardial silhouette And if you're normal there, you continue going on, and then you're going to look at to see if it's too big or too small of the heart, and you can evaluate that with the size. And so usually the rule of thumb is that you grossly evaluate the size of the heart, and it does not need to be more than 2/3 the size of the intrathoracic wall to wall. So the position as well, if you see shifting, if the heart is only in the left chest or only in the right chest, well, if it's only in the right chest, then you might have dextrocardia, which is an interesting aberration. But that being said, if it's only in one side or the other, it doesn't cross the midline, then you have some problems. There's a big left axis deviation or right axis deviation. In addition, if it's switched in terms of the apex of the heart is distorted, then that might be a pathological or normal variant, both of which must be applied with the context of the patient. So congestive heart failure, you're looking at the lungs to see if they're full of water. You can also use your ultrasound and assigning for curly B lines. And the way I always remember with curly B lines on ultrasound, it's like a blast off from a rocket. And so if you see these straight lines, which is indicated by this arc right here, then you're passing the ultrasound waves through the water. Now, obviously this is an X-ray. You're not really going to be able to see curly B and curly A lines. They're putting in this for kind of a context. But what you can see on the X-ray is what they call arborealization, which arboreals, trees. If you see ferning and tree-like distribution of the bronchial markings all the way out, and normally you'll be able to see some markings, but if you have engorged markings out to the pleural extremis here, then most likely you're going to have a full hypervolemic patient that's going to require some diuresis. Moving on to the hyla, commonly forgotten about, not really. If you're really good with the hyla, it's great. If you're not, well, welcome to the rest of us. The hyla is either too big or too small or too dark or too light. And so it also can be bilaterally engorged or unilaterally engorged. So just getting in your mind's eye that the hilum exists and there are normal sizes, and you evaluate that normal as a subjective assessment by the amount of x-rays that you look at. And if one side is just like preponderantly large, well, then that is a pathological or an aberrant finding. So looking at the lungs themselves, obviously if there's an area that's too wide or too dark, those are interesting findings. It could be some type of cancer, it could be some type of mass, some type of benign finding, could be a foreign body. You just need to be able to assess for uniformity. It should be symmetrical and uniform. If you have any type of obstruction of the blood vessels, when you have like Hampton's sign, where you have this like hyperopaque or hypoopaque region where it's so different than everything else, that could be a sign of a pulmonary embolism. And remember, the X-ray is not going to be the test of choice to determine if someone has a pulmonary embolism. So moving on to the lung size, if it's very small or hyperinflated, those would be interesting findings when it comes to, does this patient have, restrictive lung disease, obstructive lung disease? Do they have, no diaphragm, everything's flat from a hyperinflated COPD picture? Those are the things that you need to become familiar with when you're evaluating, determining like, oh, I think this patient has COPD. Do a chest x-ray and there's like flat space in the diaphragm and it's huge. You can barely get the chest in one image. Well, that indicates to you that most likely this patient has COPD, and that's a clinical diagnosis. Versus if you have the normal lungs, everything's fine, like, yeah, I have COPD. Well, it may not be COPD then. It may be something else, and that's cause for concern for more workup, either in the inpatient or outpatient setting, appropriately to the context of the patient. Also, tubes and lines in the lungs, pigtails and chest tubes. Your thoracostomy tubes are very important when it comes to the SI and the step-down unit. And although we don't do that in the clinic, but family medicine does go into the ICU in the professional setting, and we do care for patients that are critical. And you may have to put a chest tube in if you want to do urgent care and whatnot. So understanding that when you put a chest tube in, just like a central line above the navel, you need to put an x-ray order in to evaluate the appropriate location and angle at which the chest tube is in. It needs to go up to the apice. In addition to that, it depends on what kind of pneumo or hemothorax you have. If you want to drain the hemothorax, then it may need to go up or down. So those are all instances that you're going to expand your knowledge about that if you don't already know. And knowing where the location of those tubes are is of utmost importance, especially if something's still dislodged or the tube's not putting any more output. So looking at the pleura itself, this is a very important aspect. This is where you can kind of evaluate for our members who have, asbestosis, tuberculosis, although the tuberculosis is most likely localized in the apice because that's the highest concentration of oxygen. It can be pleuritic in nature. You can also see when there is aberrations of the pleura itself, pleuritis or empyema. If there's any type of unilateral changes and changing the pleural expansion or contraction, that could be an indication for pneumothorax pleural effusion, which we see on the bottom here. So other things, pseudotumor or deep sulcus. The deep sulcus is really what I want you to focus on. This is, if you see a plunging costophrenic angle, then that is a high indication that this patient may have a pneumothorax. And if they're having shortness of breath or some chest pain or whatever, COPD or asthma, you need to be able to identify that so that you can get them to where they need to go expediently. So the chest wall itself, you're looking at the bones, looking at for ribs, the cortical outlines. This is a hard thing. There's been many research articles published both from radiology and outside of the radiological specialty that indicate that the chest x-ray and the rib x-ray series isn't the best when it comes to looking for bony injury. If you're concerned this patient has a rib fracture and it's like maybe 1 or 2, that's a supportive care kind of a thing. NSAIDs, managing it as necessary. But if they're coming in, they got flail segment, all that stuff, we can do a chest x-ray and they probably will find it. But those patients need CT scans, and those patients are going to be in the emergency department. If you have any type of like hypoopacity here when it comes to like the chest wall, in context of the patient is having some type of Paget's disease or metastatic prostate cancer, multiple myeloma, things like that. If you do a chest x-ray and you see this like whiteout, destruction, cortical bony destruction, this is something that needs to be followed up with surg-onc and our hem-onc fellows. So the diaphragm is very important. If you have the diaphragm really high on one side and not in the other, well then we're going to have some problems. So we need to be able to identify where that is and being able to make those critical decisions based on the context of the patient. And one thing that you cannot miss is if the diaphragm has black or a hypoopacity underneath it and it's not a gastric bubble. And if it's on the right side, then that is a surgical emergency. The patient goes in for an acute abdomen. So air in the abdomen is not normal unless it's in the intestines. All right, so let's go over example 1. So when we go through here, I'm going to use the ABCDE method. That's the one I'm most familiar with. So if you go down, you go with the airway, look at the trachea. You can see here with your mind's eye, here's the bronchi, both right and left. I'll draw it out for us. So we come down here and we see that this is going to be the carina and the bronchi, and it goes up. And if you see that in your mind's eye, you can say, oh, okay, well, if I had a tube in here, which I'll draw, then I need to be right around here because that's going to be the 3 centimeter mark. And you can use the measurement tool on your PAC system to determine where that is. So going in your airway, your trachea, it's midline, there's no tubes, and we go and evaluate our carina and our right and left bronchi, our main stem rather, and then we go to our B for our lungs. So we're looking around, and then this might be a little like, whoa, that looks like a little pneumothorax. Well, it looks like a pneumothorax. But if you look closely, there are some markings that actually go to the extremis here. And so we continue to go down, looking down, down, down. Our costophrenic angles are there. They're not blunted. They don't look very deep. This one may be a little deep, but this isn't the best x-ray because the X-ray technologist needs to be able to capture until you see the bottom of it. So if you're concerned contextually that this may be a problem, then you need to evaluate for another image and say, hey, you didn't go deep enough. That being said, when we go over here to our hilum, everything looks pretty equal. Have a little bit of maybe some congestion here, maybe not, who knows. Contextually, that's where you go and to evaluate the patient. Then you look at your heart, it's less than 2/3. It looks like it's aiming to the left, which is great. Here's the right ventricle, a little bit of the left ventricle, right atrium right here. And remember, your left atrium is posterior, so you don't see that one. And then you look at your diaphragm, looks pretty equal to me. Right is greater than left, that's where the liver, no air in the diaphragm. And then everything else, I don't see any tubes, drains, lines. And so this is relatively a normal chest x-ray. And so just reviewing the anatomy here, you know, there's the trachea, and then this is the right paratracheal stripe. Never used that before. The aortic knob, the pulmonary trunk. Here's where your left atrial appendage is going to be. You know, like I said, you don't really see the left atrium, but remember, you're looking through the heart. So this is to determine, like, hey, this is where it's but this is not what you're going to use for diagnostics for the left atrium. Left ventricle, the periaortic line, the esophageal recess. Again, specialized terms that I've never used before, but you know, if your aorta is pretty predominant, it's going to be bright white, and you'll be able to see it through the heart, and that's where you can say, oh man, that's a big aorta. And the reason why it would be so bright was because all iron. And then here's your right atrium, your right ventricle's over here, and then your interlobar artery from your hilums. So let's look at this one right here. This is not a normal chest x-ray. There's some things, and then you know, your mind's eye looks and says, oh man, there's something there. So let's go into the steps, all right? So remember, A, B, C, D, E. Here's our trachea, and there's my line, okay? And then kind of go over here. Can't really see the carina very well, but in my mind's eye, it's there. So it's there. We're not really deviated. Looking more towards my my carina and my hilum, I don't see anything. Some congestion here a little bit. And when you go to your B for your lungs, starting on the left side, we see a little bit of hilar congestion. There's your aortic knob. Don't really see pneumothorax. And we go to the right side and we're like, oh man, what is this? This is bad. So this right here is a lobar distribution of an infectious process, most likely an infectious pneumonia. And so this individual had a lobar pneumonia, and you can see costophrenic blunting right here, okay? And so this patient's got a pneumonia. One thing that I do want to point out to you is that this patient's x-ray isn't the best. It's very difficult to discern between the lumbar and the thoracic vertebra, and the patient, although not malrotated, it's the exposure that's the problem in this x-ray. So it makes it difficult, but we get the point. The patient has something wrong with them. Moving on to the cardiac, it's less than 2/3. The diaphragm is relatively equal, no air into the diaphragm, and then we have no lines, tubes, or drains. So this example is an example of bacterial pneumonia. So moving on to this one doesn't look so hot either. Going down with our ABCDE and just our quick snapshot view, it looks like we got something wrong with the lungs. Okay, it looks like they're not black, they're not white. It just they're just messed up. So moving on, we see the trachea. Here's our trachea and our carina. There is the trachea, it's midline. I don't see any endotracheal tube in the patient. Going down to the hilum, they look a little different, not so hot. And looking at our heart, we see that the heart is less than 2/3. It doesn't look like it's rocked. It doesn't look mal-rotated. And then going into our B, which I skipped, and we see that this is like this pattern of just diffuse generalized hyperopacities. And you see the pleural lines to the extremis all the way around. Doesn't look like there's pneumothorax going on. Costophrenic angle is not blunted, but we do see this kind of, they call it ground glass appearance. It's just like specks of glass and sand in the chest. So no lines, tubes, or drains. So take a moment to think about what this can be. this diffuse ground glass appearance everywhere. That could be a viral, it could be a fungal, bacterial. If you said PCP pneumonia, you are correct. Okay, so PCP pneumonia with our HIV patients, CD4 count less than 250 needs to have our Bactrim, and a CD4 count less than 50, we have to worry about our MAC and treating them with azithromycin and Bactrim as well. These patients can die very quickly from PCP pneumonia. And remember, the mnemonic or the hot button word for PCP pneumonia is bat wing appearance. I don't see a bat wing. I've seen bats. They don't look like that. But there are kind of pathognomonic images that you can see that do kind of have that outcroach into the right and left apice and midline lung field. So this right here is not very good either, and you notice it's different. It's not as coalesced as the previous X-ray we had before. It still is determined as ground glass appearance. And going with our ABCDE, so as we follow down the paratracheal spike right here, there is our airway. Here's the carina, it's midline. Going down our B, I mean, we see these lung markings outside. Not a very good X-ray, hyperexposed, and we don't see the phrenic angles as well. We don't see their termination points, so you're going to get it top and below. And you see this as this global diffuse changes. So with these patients, you know, looking at the heart, it's less than 2/3. It's not rotated. There's the aortic knob. The aorta's right here, doesn't look overly enlarged. And then our diaphragm, nowhere under the diaphragm, there's our gastric bubble. This patient is not well. His lungs look bad. And if in context the patient's not doing well, you know, they need oxygen, you know, you can run some tests, you know, in the line of COVID and all of this stuff. This could be COVID, this could be miliary TB, this could be viral pneumonia. And in this case, it's viral pneumonia. And viral pneumonia, this is a moderate to severe case. It's bad. This patient's sick. They're going to need some supportive care for sure. And another thing that you have to worry about is that if the patient doesn't present poorly and they do still have this X-ray, then you need to be concerned on day 10 to 20 if the patient is not doing so well and then they just kind of crash out, then it may be a bacterial superinfection with staph or strep. And so that's the time that you need to keep in your mind's eye that, hey, we've reached that limit that you might have a superinfection from the viral inflammatory processes that have destroyed the cellular boundaries that existed beforehand. So moving on to the rib fracture area here, and I say this because I want you to not like pull your hair out about this, but going down ABCDE, so we go from our airway down here. Okay, moving up, there's our carina and our trachea, and it's pretty midline, everything's fine. B and our bones, and you can see that we have some little snap. The way I learned it was that if you can imagine your mind's eye running your finger over a rib and feeling on that rib, if you have something that would hurt your finger, that's probably something that you need to develop further. Looking at the lung fields and everything else, I don't see any pneumothorax. Here's the clavicular inlet, and it's kind of, this picture was kind of taken with the patient. Well, the X-ray was a little bit down, so you're kind of looking up towards the patient's head. So that's why you have this kind of view. If you can imagine, the X-ray beams are facing towards the patient, not on the patient, so to speak. Looking at the hilum, everything's fine. The heart is not greater than 2/3. The diaphragm is there. A little deep costophrenic angles here. Again, that's because the way that this was filmed. So you would need to request for a second one. Good exposure, no malrotation. So rib fractures 1 and 2, you know, and then you don't want to look at here and say, oh man, well, what's going on here? Well, remember, X-rays go through things, and so it may appear as if these bones are being withered away. But if you do have some high suspicion of some type of cortical destruction from cancer, that's something that you need to get a CT for. So let's move on to this one. This is example 7. ABCDE airway. Oh, looks like the trachea is moved a little bit over. Sorry for that little wiggle line there. So we have a movement. Okay, so if the trachea is deviated towards one side, that means something's pushing it towards that one side. So that's a first hint. And then our bones and our lung fields. So we go down over here and we don't see any gross changes. The hilum and the lung markings are pretty congested. But when we go over here, I see no lung fields. It looks like a beautiful just x-ray that I can see these bones. This is perfect. Well, that's not normal. And if you see the lung markings right here, that is a bad day. This patient has complete deflation of the left lung, both superior and inferior lobes. It is a bad day. This patient needs to have a needle thoracostomy right away to release the pressure so you do not have a tension pneumothorax, and then they need to have a thoracostomy tube placed in the 5th or 6th intercostal space mid-axillary in order to allow for the reinflation of the lung. So remembering that is very important because you don't want to be distracted from, they're like, oh yeah, you know, what's going on over here, but there's a complete absence. And I'm sure none of you would miss this pneumothorax. This is pretty big. So moving on to this one also does not look normal. This is not a normal finding right here, this hyper opaque area. So going down with our airway, here is our airway and our trachea and bronchi. Looking down on the bones, I don't see any acute fractures. Heart less than 2/3, the diaphragm, I can't even appreciate the right side. And then everything else, costophrenic angle not blunted. But this, what is this? It's just so hyper opaque, and I can't appreciate any other anatomy from it. This would be an effusion or an empyema. You don't know, obviously, by a chest x-ray. You need to follow up with a CT scan. So this needs to be evaluated for further. And remember, this is where you would use your Leitz criteria, your LDH and your serum LDH and serum proteins, to determine whether or not it's transudative or exudative. And that's where you would apply that knowledge. Now, additionally, you see this little thing up here. This would be contextually like, why do they have this? Because it's not over here. What's going on over here? Does that mean that they have tuberculosis? Maybe. Tuberculosis can cause effusions, or a malignancy that can cause a malignant pleural effusion. So you need to remember not lose the forest for the trees and keep the whole evaluation of the chest x-ray. So this is an example of a right pleural effusion. So let's look at this one. Man, what is going on here? So we look over here, we have our airway. Here's our trachea coming down over here. All right, pretty deep. It's a deep little airway here. No mean line deviation. Looking at our bones, no bony breaks. Here you see your electrodes. Okay, there's an electrode right there on his little right humeral head. Moving on, we don't see any lung markings because they stopped right there. And if you didn't see that right away, that's okay. But in your mind's eye, I'll erase this. Need you to look at this for a minute. Here's the line. Here's the pleural line right there. And so another huge thing, just kind of like we saw with the last x-ray, is that I cannot appreciate anatomy on the right side. It looks like a big old container, and it's hyper opaque. Well, you have I'll say it at the end, but if you remember, this is most likely blood. It's leveling out, and you have absence of lung markings to the outside of the wall here. And so this is I'll draw the letters, pneumothorax. Okay. So this right here is an important part, okay, because, with critical care, it's very important to understand what you're doing and where your things are, okay? So this patient is malrotated. It's not a very good. It's hyperexposed. You see that these lungs do not look normal. The left is hyperinflated or hypoinflated. The right is kind of normal, but it's just, you really can't see much. It's just not a very good film. But what I want to tell you is, remember, going through A, B, C, D, E is very important because you can miss things, all right? So A, we have a deviated trachea, but that might be because of the malrotation. Here's the carina, and then we see something coming down here. What is this? This is the endotracheal tube, okay? So it's a little deep, probably needs to be pulled back a little bit. Remember, 3 centimeters from the carina for flexion extension of the neck, and less than that for the child. Then you go into the B for bones. I don't really see any cracked bones around here, but like we mentioned before, really can't appreciate the lungs very much. And then our C, this is where our heart is. Okay, it looks to be a little big, all right, but that may be the exposure of the film. Our hilum is kind of enlarged, but that might be the lung itself. And we'll talk about that in just a second. The diaphragm looks pretty much equal. We have some like hyperopacities over here. You have blunting of bilateral costophrenic angles, which is a problem. And then everything else, tubes, lines, and drains. So we already mentioned the endotracheal tube right here. We see on this side, what's this? That's subcutaneous emphysema. That's bad. And then you see air tracking right here. I'll erase that so you can see that again, but that's not normal. But more importantly, the topic of this right here is this right here. Okay? This is not normal. This is a chest tube. The chest tubes are supposed to go in here. This chest tube's going like that. This is a malpositioned, misplaced chest tube. You'll notice that they did do the appropriate positioning, but they did not appropriately place it. And this is a error that happens whenever you place it. You must do the finger or the forceps directly into the air spaces and feel or hear the whoosh of air. You can feel the lung with your finger when you put it in appropriately. And so this was an inappropriate placement because this generated a tract. And you'll see this chest tube went all the way up into the supraclavicular space. Bad times. And then this right here is the endotracheal tube right there. There's no central lines or anything that we can appreciate on this x-ray. Here's an electrode. So, you know, when you put a tube in, you got to know where it's at. So let's talk about the final x-ray here. So going through our airway, we have our trachea and carina. You see this coming in here. This is our endotracheal tube, not displaced, malrotated a little bit. You might ask yourself, why is it like coming at an angle? Well, I don't have a good answer for that, but the chest tube, or excuse me, the endotracheal tube is in place appropriately. You have your bones, don't appreciate any cracks anywhere. And then you go to cardiac, less than 2/3. Here's your cardiac silhouette. Diaphragm, no air in the diaphragm. The costophrenic angles are a little blunted, maybe a little bit. And then everything else, then drawing, you can see your hyperopaque line. And this is your chest tube. It's appropriately placed, the 5th or 6th intercostal space. And it goes up to the apice, which is where it's supposed to be. Here are your electrodes, okay? This right here is your tube tamer, okay? This is what holds the endotracheal tube in place. That's what that kind of little shape is. But you need to be able to assess that this chest tube is in the right place. Well, I hope you learned a lot of stuff from this x-ray review. If you have any questions, we'll be more than happy to answer them for you, and thank you so much.